Hi guys, welcome back to the MedEd Real Harrison series. Dr. Patil here, and today we will be learning about hemochromatosis. This is one of the most requested topics in the recent days. Of course, I understand that your around, like your university exams are just around the corner, and this is one of your 5 or 10 mark question, and maybe some 2 or 3 marks questions may be also asked from the topic. So we'll try to address it from both, from the practice perspective, from the NEET PG and ACT perspective, as well as from the perspective of your prof exams. So let me start with the definition. What is hemochromatosis? So primarily hemochromatosis refers to iron overload. If our body iron store is having higher than normal amount of iron that it can handle, we will call it as hemochromatosis. Now when iron overload happens, whether the iron overload affects a selected organ or multiple organs, yes, it's a multi-organ iron overload disorder which is characterized by It's a multi-organ disorder characterized by systemic iron overload. Systemic iron overload. Now, to understand the disease better, we need to quickly revise the iron metabolism in the body, and then rest of the things become easy for us. Now, when we talk about iron metabolism, of course, we know iron is essential for hemoglobin and various other functions iron does in human body. The question is from where we're getting this iron. Yes, we're getting the iron from the diet, and the dietary iron will be in two forms. The first, mainly the non-vegetarian food, will have iron in heme form, the heme iron, and the vegetarian diet or the vegetarian sources will have non-heme iron. The heme iron is easy to absorb because we have dedicated iron transporters. Now, imagine that this is the lumen of the intestine. These are the intestinal epithelial cells. And on the other side of the intestinal epithelial cells, we have the blood vessels. So the nutrients will be absorbed into the intestinal epithelial cells and then will be shuffled into the blood vessels. And from the blood vessels, it will go to the circulation. This is how the basic digestion and absorption of nutrient works. So we are now looking at the iron absorption. Now the heme iron on the intestinal epithelial cells, the brush border cells, the brush border epithelium, we have a dedicated transporter called as heme transporter. So I don't need to do much about this heme iron. It will be absorbed into the circulation, into the intestinal epithelial cells through heme transporter. But the non-heme iron, I have a problem. What is the problem? The non-heme iron, that your fruits and vegetables, the iron that they contain is in ferric form. It is in ferric form, that is Fe+3. The ferric form of iron cannot be absorbed. So first I have to convert it to ferrous form and then absorb it. So how will I convert this to ferrous form? We have an enzyme, that is ferric reductase. The enzyme is called as ferric reductase, expressed in the cytochrome B on the brush border epithelium. Now this ferric reductase will convert this iron into ferrous form, and ferrous form can be easily absorbed because for the ferrous form of iron molecule absorption we have a dedicated transporter. This transporter we are going to call it as DMT1. It's there in the name. It says divalent iron, we know it's a metal, transporter 1. So divalent metal transporter 1. So now this divalent metal transporter 1 will shuffle this iron into the into the intestinal epithelial cells. So now I have this ferrous form of iron inside the intestinal epithelial cells. Now some of it will be stored in the epithelial cells itself, and some of that will be packed to the blood vessels. Whatever that is going to be stored, it will be stored in the form that we call as ferritin. So we know that ferritin is the storage form of iron. Ferritin is the storage form of iron. Now this remaining ferrous iron molecules will now be shuffled out from the intestinal epithelial cells into the blood vessels. Again, I need a transport molecule, and this molecule we will call it as ferroportin. Again, it's there in the name, ferroportin. So we are pushing the iron out from the intestinal epithelial cells towards the blood vessels. But again, the same issue. The iron that I'm getting here is now in the ferrous form. This again need to be converted to ferric form to transport this iron, because most part of the iron will be bound to a transport protein and then transported through the blood. And that transport protein, we are going to call it as transferrin. The transport protein is going to be transferrin, which primarily binds the ferric form of iron. So conversion of this ferrous to ferric is done by an enzyme called as hepastin. The hepastin will convert the ferrous form of iron to the ferric form again. Now this ferric ion will be loaded onto the transferrin molecules, and once it is loaded onto the transferrin molecule, you can say that this transferrin molecule is now saturated by iron, and now it will be transported. We all know that the blood from the intestines primarily goes to the liver, and from there it will make its way into the systemic circulation. So this ion is now entered into the portal circulation. From there it will go to liver. Once the ion reaches the liver, some amount of this iron will be stored in the liver and some will be distributed to the different tissues in the body, like for example bone marrow for the hemoglobin synthesis. Excess iron will be stored in the liver. Again, what is the storage form? I will store in the liver in the form of ferritin. Ferritin is our storage form. So what we learn now, transferrin is the transport form, ferritin is the storage form. Now, our diet may contain very high amount of iron, more than what we need. So in that case, how will I regulate the body iron stores? Because if I keep absorbing too much of iron, I will load my body with excess amount of iron, which can be toxic. So the regulation is primarily responsibility of liver. So once liver recognizes that the iron stores are increasing, we need to stop absorption of iron from the intestine. How will we stop? Liver will release a substance called as hepcidin. This hepcidin, as we know, is called as the master regulator of iron metabolism, because this hepcidin is capable of blocking this ferroportin. Hepcidin can block ferroportin. So once sufficient iron is stored in the liver, it releases hepcidin. Hepcidin blocks the ferroportin. Now the iron can get into the intestinal epithelial cells but can't make its way into the bloodstream. Right? That's why hepcidin is considered as the master regulator of iron metabolism. How does it influence? Hepcidin inhibits the ferroportin, thus decreases iron absorption. Now, at the level of liver, to recognize that the iron stores are sufficient and I don't need to absorb the iron anymore, there are complex interplay of various chemicals. At this level, it's an overkill for us to try to understand exactly how liver recognizes that the iron stores are increasing and we need to stop. But I just want to tell you that there are few genes which may be playing a role in the expression of hepcidin. So one such gene is HFE. The other gene is hemojuvelin. Then there is another gene called transferrin receptor 2. Transferrin receptor 2. So these genes or these gene products may be responsible for liver's sensing of iron store and thus time it appropriately for the hepcidin release. Now imagine if I have mutations in these genes, then liver may not be able to sense that the iron stores are getting supersaturated and there is probably increase in the liver iron store more than we need. And if there is such condition, I may not be able to release the hepcidin. If I do not release hepcidin, then ferroportin won't be blocked. So in that case, we continue to absorb iron even when the liver and body stores of iron are sufficiently full. This condition, we will call it as hereditary hemochromatosis. So in hereditary hemochromatosis, why are we having iron overload? The reason we have iron overload is probably these mutations, so that liver now is not able to release the hepcidin as per the need, and thus ferroportin cannot be blocked, and we continue to absorb iron even when our body stores are full. We will call it as hereditary hemochromatosis. We can also have secondary iron overload, where these mechanisms are not involved. There is no abnormality of any of these genes, but probably because of the iron therapy. Like for example, someone is having anemia and she or he has been prescribed iron supplementation but takes it in high quantities, or when someone is going through repeated blood transfusions for whatever indication, there can be because every transfusion brings a large load of iron into the body, we can get into iron overload. In that case, we will call it a secondary iron overload, or you can say secondary secondary hemochromatosis. Right? Clear? So to summarize, what is hemochromatosis? It's a multi-organ disorder. Why multi-organ? Because now liver is not going to be the only site where iron will be deposited. Liver has a limit to which it can tolerate. Beyond that, excess iron will be stored in various other organs. Whichever organ I am choosing to store iron will start becoming dysfunctional. So that's why it's a multi-organ disorder characterized by systemic iron overload. This could be secondary or hereditary. If it is hereditary, the main mechanism is impairment in the reduction of, impairment in the hepcidin secretion or other mechanisms, so that we are not able to stop iron absorption even when iron stores in the body are full. This is the main mechanism in hereditary hemochromatosis. Clear? Now let us understand the disease. Hemochromatosis, as I just told you, it's a systemic iron overload, and the causes will be divided into hereditary. In that case, you can say hereditary hemochromatosis and secondary iron overload. Secondary iron overload. Now, what are the common causes for the hereditary hemochromatosis? Medico, yes, vitamin C increases the iron absorption, and phytates in the food decrease the iron absorption. Okay, so this hereditary hemochromatosis is because of the mutations. The most common mutation that we can encounter in these patients is in the gene called as HFE. I just told you that there are three important genes to remember: HFE, HJV, which stands for hemojuvelin, and transferrin receptor 2 mutations. So in the HFE mutation, it can be either a point mutation at position 282, we will call it as 282 mutation, that has to be homozygous, or we may even have a heterozygous mutation where one mutation is 282Y plus we have another mutation that is H63D. In that case, it is a heterozygous mutation. So either homozygous mutation 282C 282Y in the HFE gene, or one mutation that is C282Y in one HFE gene on the other HFE gene, H63D mutations. These are more common causes for the hereditary hemochromatosis. So you can say that hereditary hemochromatosis can be further divided into HFE gene related and non-HFE gene related. Like other mutations are non-HFE. So the other mutations include mutations in hemojuvelin, HJV, and transferrin receptor 2. Okay. Secondary iron overload, it can be iatrogenic or disease related. Now let me give you a table where all the common causes for, like not just common, but even the rare causes for hemochromatosis or iron overload are mentioned. So first that we were talking about is hereditary hemochromatosis, and I just told you that I can divide that into HFE gene related and non-HFE gene related. HFE gene related, the homozygous mutation C282Y is overall the most common mutation that we encounter in hemochromatosis. Other than that, we can have a compound heterozygosity where one gene carries C282Y mutation, the other gene carries H63D mutation, and other mutations in HFE. Non-HFE includes hemojuvelin, hepcidin, transferrin receptor 2. So these are all non-HFE. So these are all causes for hereditary hemochromatosis. For non-hereditary or secondary iron overload, it could be the iron loading anemias like aplastic anemia, sideroblastic anemia, or thalassemia major, or it could be like in those conditions, even the treatment, like for example, someone is having aplastic anemia or thalassemia major, they will go through repeated blood transfusions. Every transfusion brings in a big load of iron. Then second, it could be parental iron overload when we are giving them treatment in the form of iron dextran injection or patients on hemodialysis. Then even in patients with chronic liver disease, we can have secondary iron overload. These are secondary causes. These are primary causes. In the exam, mostly they will ask you to write about hereditary hemochromatosis. So you should be remembering these mutations, particularly C282Y homozygous mutation is the most common mutation responsible for hereditary hemochromatosis. Okay. Now these are all causes. It could be secondary iron overload or hereditary. Regardless of the cause, what manifestations we're going to get? The iron start getting deposited in different body parts or body tissues, and those tissues start becoming dysfunctional. Let us say that there is an individual who is having this HFE mutation, the most common C2A2Y mutation, homozygous state. Does that mean that by birth he will present with the hemochromatosis and all organ system involvement? No. As the individual with this mutation keeps growing, he is absorbing a lot of iron. His iron absorption is unchecked. So organs start getting saturated with iron. Only when the threshold of tolerance by that organ is exceeded, that organ starts becoming dysfunctional. So most of these patients present with the features of organ involvement in fifth decade of life. Means when they enter their 50s, not in their 20s or 30s. Some mutations, especially non-HFE mutations, the patients may present early, especially in juvenile age group. Otherwise, overall speaking, keeping in mind the most common mutation, the usual age of presentation is fifth decade. Fifth decade. Now, what is the most common presentation? Even in those who are presenting in fifth decade, most common presentation is asymptomatic. Means they come to hospital for some other investigation, and as part of the general investigation, we may end up doing iron indices, the serum iron level, the serum ferritin level, transferrin saturation, and they may be elevated. And that is where we start suspecting that, okay, this individual may be having hemochromatosis. Only few at this age would present with organ involvement. I'm not talking about the juvenile presentation of certain mutations, but overall, generally speaking. Now, if they're presenting with organ involvement, what is the most commonly affected organ? Of course, liver is the primary site of storage of iron. So, most commonly affected organ is going to be liver. Most common affected organ is going to be liver. And what is the most common presentation of liver? The most common presentation of involvement of liver is going to be increase in, like, asymptomatic increase in the AST ALT levels. So increased AST and ALT levels, again found mostly on routine screening. But the problem doesn't stop here, because as I keep adding more and more iron, this iron is getting stored, especially in hereditary hemochromatosis, in the hepatocytes, the liver cells. In case of secondary iron overload, like for example, someone with thalassemia major getting repeated blood transfusions and all of that, bringing iron, that will be stored in the reticuloendothelial cell, that is Kupffer cell in the liver. Here, the storage is mainly in the hepatocytes, the main liver cells, and those cells die because of the iron toxicity, and we end up with cirrhosis. So here it can cause cirrhosis of liver. Not just the cirrhosis of liver, there is increased risk of hepatocellular carcinoma. How much increase in the risk we can expect compared to someone who does not have any other risk factors for hepatocellular carcinoma? Means someone who does not drink, no exposure to toxic drugs, no exposure to hepatotropic viruses like hepatitis B or C. That person, we can say a general person, and patient with this HFE mutation and having hereditary hemochromatosis. The risk of getting cancer increases, hepatocellular carcinoma increases by 100x. So there is 100x increase or 100 times increase in the risk of developing hepatocellular carcinoma compared to general population. So liver is the most common affected organ. Most common presentation is just asymptomatic elevation in AST, ALT levels. But if the disease is advanced, patient may end up with cirrhosis. He may present at the stage of cirrhosis, and some of them may end up developing hepatocellular carcinoma. The risk is staggeringly high. And if there is cirrhosis happening, often from the pathology, they would ask what kind of cirrhosis we are expecting. Means we can classify cirrhosis into micronodular and macronodular. So here we are expecting to see micronodular cirrhosis. Micronodular cirrhosis. Okay, so liver is the most commonly affected organ. What other organs can be affected? Second organ that is particularly examiner's interest is joints. There can be deposition of iron in the joints, and iron in the joint deposition would cause arthritis. Arthritis here affects mainly small joints of the hands. Particularly speaking, the second and third metacarpophalangeal joints. This is a particularly important MCQ point because they often ask this pattern. Where do you get this selective involvement of second and third metacarpophalangeal joint? You can answer hereditary hemochromatosis. Apart from that, in lot of questions when examiner is discussing various examination findings, if he mentioned that patient has got second and third metacarpophalangeal joint arthritis, it's a potential clue that examiner is talking about hereditary hemochromatosis in this question. Okay. Then there can be iron deposition in the skin. Doesn't cause any particular skin dysfunction per se, but changes the appearance of the skin, the complexion changes, and there will be bronze colored, deep bronze colored pigmentation of the skin. Bronze pigmentation of the skin. Okay. Where else the iron deposition is going to cause trouble? Iron deposition in the pancreas can cause trouble because iron deposition in the pancreas, now the pancreatic cells become destroyed by this iron. So we'll end up developing diabetes mellitus. Diabetes mellitus because the pancreas is destroyed by iron deposition. Similarly, iron deposition can happen in the pituitary gland, and pituitary glands lose ability to produce the pituitary hormones. What are the pituitary hormones? Prolactin, TSH, ACTH, FSH, LH. These all, their production can come down. Particularly, the production of TSH and FSH, LH gets affected the most. So what manifestation I'm going to expect because of that? There will be decreased FSH and LH production. What should I call this as? What should I call this as? These are gonadotropins. So their production is reduced. So we'll have hypogonadism because of decreased gonadotropins. So we'll have hypogonadism. In the sense, in males, the testicular action; in the females, the ovarian function will be affected. So males, because of the testicular dysfunction, there will be low testosterone. They can have reduced libido. They may end up developing, like they may lose the male characteristics, and they may have some feminizing features like gynecomastia. In females, the lack of ovarian hormones can cause amenorrhea. In simple words, we will call this as hypogonadism. And decreased TSH. This will cause hypothyroidism. Of course, thyroid gland is not the problem here. The main problem is in the pituitary. So I can't call it as primary hypothyroidism. We will call it as secondary hypothyroidism. When thyroid gland itself is dysfunctional, we will call it as primary hypothyroidism. As like, for example, in patients with Hashimoto's thyroiditis, there is damage to the thyroid gland itself. Thyroid gland is not able to produce TSH. So you have hypothyroidism. Problem is in the thyroid gland itself. So we'll call it as primary. Here, thyroid gland is fine, but pituitary is not sending the signal to stimulate thyroid gland to release the hormone. So we'll call it as secondary hypothyroidism. So these are the manifestations we are expecting. Now, often in the exams, you come across this term called as bronze diabetes. What is bronze diabetes? Patient with bronze skin pigmentation having diabetes because of hemochromatosis. They also ask you about the triad of hemochromatosis. So what is the triad of hemochromatosis? So in this triad, we have the same features that we have already discussed. One of them is diabetes because of the pancreatic destruction by iron deposition. The second one is bronze skin pigmentation because of again iron deposition. And the third one is liver involvement or cirrhosis of liver. This is called as triad of hereditary hemochromatosis. Right? So this completes the clinical features that we are expecting. The main brunt of this iron overload is borne by liver, pancreas. This is what I want you to remember. Liver can get into cirrhosis and increase risk of cancer. Pancreas can lead to diabetes mellitus. Most of the patients, except some juvenile conditions, they are going to present in their fifth decade of life with these features. So when someone presented to me with all these features, now my question is, how will I establish the diagnosis that yes, this is iron overload? There are n number of causes for diabetes mellitus. There is insulin resistance, lack of insulin production because of autoimmune damage to the pancreas. So there are a lot of causes: drugs, steroids, cirrhosis. There are plenty of causes. Right? Alcohol being still the most common, and then equally important cause nowadays is non-alcoholic fatty liver disease or metabolism associated fatty liver disease, as we call as NAFLD or MASLD. So there are plenty of causes for hypogonadism, hypothyroidism. So how will I establish that this patient is indeed having the problem because of hemochromatosis? In terms of clinical examination, bronze skin pigmentation may be a potential clue to think towards this, but still we have to rely on the lab. We'll have to talk about the lab diagnosis in terms of initial screening and then confirmatory testing. Initial screening, we are looking at two tests. One is transferrin saturation. So while talking about the iron metabolism, I told you that storage form of iron is ferritin and transport form is transferrin. So transferrin molecules bound with iron are called as saturated transferrin molecules. So what percentage of transferrin molecules are saturated is what we're going to estimate. That's transferrin saturation. We will also look at the quantity of the storage form, that is ferritin. So we'll estimate these transferrin saturation and serum ferritin levels. So if transferrin saturation is more than 45%, that means it is increased. It is suggestive of excess iron. And if serum ferritin is more than 300 micrograms per liter, that is also increased. So when both these parameters are found on the iron indices, it's highly suggestive that you have iron overload. Now I have to go for confirmatory test. If both these tests turn out to be normal, the transferrin saturation is less than 45%, serum ferritin is less than 300 micrograms per liter, probably what you're suspecting as hereditary hemochromatosis may be something else. There may not be iron overload. So we don't have to jump to the confirmatory testing if these values come out to be normal. But now I've got it done and it is high. So how will I confirm the diagnosis? The confirmatory testing will primarily focus on the genetic studies. Genetic studies for the mutations, whatever we discussed already. The HFEC2A2Y mutation is the one that will be first tested because that is the most common mutation. If not found, then other mutations will be tested. So if mutations are positive, I don't need any further investigation because iron indices have already told me that there is iron overload and this mutation is also found. Done. You have the diagnosis of hereditary hemochromatosis. Right. But if you are in doubt, you want to do a gold standard confirmatory investigation, the gold standard confirmatory investigation will be liver biopsy. Liver biopsy. So what am I going to find in the liver biopsy? In the liver biopsy, there will be iron deposition in the hepatocytes, not in the Kupffer cells, in the hepatocytes. So we can use special stains to stain the iron and we will notice that there is iron deposition in hepatocytes and not Kupffer cells. In case of secondary iron overload, the iron deposition will be in the Kupffer cells. First point. Second, now I can quantify the iron. We will call it as hepatic iron concentration. Hepatic iron concentration of more than 4 milligram per gram, more than 4 milligram per gram of the dry weight of liver. It's highly suggestive of iron overload. We will call it as hepatic iron concentration. Okay. Now after this confirmatory testing, most cases we don't have to go for the liver biopsy. We will be able to confirm or refute at the level of genetic studies itself. So from the genetic studies, I have confirmed. How will I manage? Okay, so before we go to the management of hemochromatosis, let me give you an algorithm that you can use to answer questions, MCQs, for the management of hemochromatosis. So if you're suspecting hereditary hemochromatosis, the first investigation that I would do is serum transferrin saturation. If it is more than 45, it is favoring the possibility of iron overload. If it is not more than 45, then we have to think of, it is suggestive of an alternate diagnosis. It may not be hemochromatosis. But if the transferrin saturation is 45 plus, we will look at the serum ferritin. If it is elevated, means more than 300 micrograms per liter. Now both the tests are positive. Transferrin is more than 45%. Ferritin is more than 300. I have to go ahead with the genetic studies. In the genetic studies, we will primarily, the first genetic abnormality I will be looking for is the most common mutation, which is C282Y homozygous mutation. If it is present, the diagnosis is established. If it is present, it confirms that you have hereditary hemochromatosis. If it is absent, it does not immediately rule out. We have to test for other mutations. And if other mutations are present, again, it still confirms hereditary hemochromatosis. And once you confirm that, okay, you have hereditary hemochromatosis, now I have to evaluate for the organ involvement. For liver, we will do LFT, we will look at AST, ALT levels. If I want, I can do an MRI, Ferri scan, which can quantify the amount of iron in the liver. For the pituitary, I have to look at the pituitary hormones. The minimum test I need to do is TSH, FSH, LH. For diabetes, of course, I need to do HbA1c, ABS, PPBS, other blood glucose indices. Nowadays, we are also monitoring with the CGM. So whatever organ involvement we are suspecting, I have to investigate. So now at this stage, I have the diagnosis established and I know what is the situation of my individual organs. Organs themselves may need supportive care. For example, if I have developed cirrhosis, I have to think of liver transplantation and I have to think of the management of cirrhosis. If I have developed diabetes, your pancreas is destroyed, patient will not be able to respond to any of your conventional oral antidiabetics, because oral antidiabetics either reduce insulin resistance or increase insulin secretion or use other modes for getting your blood glucose normalized. But here the main defect is pancreas damaged or destroyed, decreased insulin production. So patient might require insulin therapy. So of course, on one side, organ supportive care, other side, organs will continue to fail or become dysfunctional more if more and more iron get deposited in them. So I have to first reduce the organ iron load so that at least remaining functions of the organ is preserved. So how can I deburden the organs loaded with iron? Because of the lack of TSH production, we will end up with hypothyroidism. Hypothyroidism. Okay. So there are two ways I can reduce the iron load from the organs. One of them is giving iron chelating agents, which will bind the iron and take it away. Or more effective, in fact, the most effective treatment that I can offer for these patients is phlebotomy. What is this phlebotomy? We will remove the blood from the patient's body at regular intervals. How does this help? Let us say I removed 500 ml of blood from the patient today. So whatever iron that was there in that blood, as free iron, as circulating ferritin, as circulating transferrin, and as hemoglobin, all of this is now out of patient's body. Now you know that, like, patients with abnormal menstrual bleeding often present with anemia. Why? Because they bleed. Every time they bleed, they lose some amount of iron. They bleed again, they lose some amount of iron. So if someone is having peptic ulcer, they can also present with anemia because they keep bleeding. And if they keep bleeding, they're losing iron from the body. So I'm doing the same thing here. I'm making the patient bleed in a controlled way so that I keep removing the iron from the body. And if I keep doing this multiple times after many cycles, the iron burden on the organs will come down. Like, for example, when I bleed, the iron from the blood is out. Now it creates a gradient between the organ and the blood. So some iron from the organ will come out to blood again. Next time when I remove the blood, this iron is again lost. So this way I can keep bringing the iron out from the organs like liver and the pancreas and the skin where it is deposited, and slowly from all the organs the iron load will come down. So in terms of management, the most effective way of managing it is phlebotomy. So if you ask me what is the treatment of choice for the hemochromatosis Of course, there is secondary iron overload, treat the underlying cause, but hereditary hemochromatosis, the treatment of choice is going to be phlebotomy. Phlebotomy. So how do I do this? Initially, when I diagnose that, okay, this is a patient with hereditary hemochromatosis, initially we will do 500 ml per week. 500 ml per week. How long I should keep doing this? So that means I'm removing 500 ml of blood from the patient's body every week. How long I will continue? Till the transferrin saturation comes to the range of 50 to 100 micrograms. Transferrin saturation drops to less than 45%, or the ferritin less than 50%, sorry. And the serum ferritin becomes to the range of serum ferritin comes to the range of 50 to 100 micrograms per liter. For diagnosis, how much did we consider? If it is more than 300, we counted it as very high. Once it is 50 to 100 micrograms per liter, now the phlebotomy has achieved the deburdening of the organs. Means organs are no longer burdened with the iron from the organ is down. But that does not mean that the problem is over, because they have mutations, and as of now we don't have any gene therapy to alter or edit these mutations. They will continue to over absorb iron. They will come back again with organ involvement. So once this is done, I have to go for the maintenance phlebotomy. Maintenance phlebotomy. Maintenance phlebotomy. So what do we do in maintenance? I don't have to do it once a week. I can do it once in 2 or 3 months. Maintenance phlebotomy is done once in 2 to 3 months. So to summarize, what are we doing? Once I diagnose there's huge iron burden on the organs, so we'll start doing weekly phlebotomy. Weekly, we will make the patient bleed 500 ml of blood. We will continue to do this till I have reached where transferrin saturation is less than 50% or ferritin is in the range of 50 to 100. Once that is achieved, I don't have to continue weekly. We will switch to once in 2 or 3 months. It is called as maintenance, where whatever iron overload or iron burden that happens in these 2 to 3 months is removed in this one phlebotomy. So that will continue throughout the life, apart from treating whatever complications that are arising because of the disease. Now, then comes the question, when do I consider iron chelating therapy? So it's not actually meant for the all patients. Iron chelating therapy is primarily useful for the secondary iron overload. Like if there is a, let us say, thalassemia patient who requires regular transfusions, and that is going to burden the body with extra iron. So that iron we can reduce with the help of the chelating agents. Here we can use it or consider using it if patient is not able to tolerate phlebotomy, or if there are some contraindications for phlebotomy. Then we consider iron chelating therapy. So iron chelating therapy is primarily meant for patients not tolerating phlebotomy or having contraindications for phlebotomy. A common circumstance that we encounter in clinical practice where phlebotomy may not be practically feasible is going to be anemia. Because anemia need not always be because of iron deficiency, as we know. So there may be other cause for this patient to have anemia, maybe B12 deficiency, or maybe some other pathology, some other nutrient deficiency, and that is contributing to the anemia. And if I keep doing phlebotomy, iron overload will come down, but the anemia will worsen. So in that case, I can't do phlebotomy. So we can consider iron chelating therapy, where we can use chelating agents like deferasirox or desferrioxime. Deferasirox or desferrioxime. So this is how we are going to manage a case of hereditary hemochromatosis, right? So let us take a quick recap of what we have learned so far. Hereditary hemochromatosis or hemochromatosis per se in general means systemic iron overload which affects multiple organs. It can be either because of secondary iron overload or it could be hereditary hemochromatosis. Hereditary most commonly occurs because of these mutations: HFE, hemojuvelin, transferrin receptor 2, or hepcidin mutations. The mutations primarily result in impaired production or action of hepcidin, and because of this, we will not be able to control the absorption of iron from the intestines into blood. And this uncontrolled iron absorption leads to excess iron content in the body. Liver is the most commonly affected organ, but it's a multi-organ disease. Other organs will also be eventually affected. So, what all organs can get affected? Liver involvement can present in the form of asymptomatic transaminitis or elevated AST, ALT. That is the initial stage, but that means the hepatocytes are getting damaged. So with time, patient will end up with cirrhosis, and a cirrhotic liver is a risk factor for hepatocellular carcinoma. Similarly, iron deposition in pancreas will lead to diabetes. Iron deposition in the joints, particularly second and third metacarpophalangeal joints, can lead to arthritis. Into the skin can cause bronze pigmentation, and into the pituitary can cause hypogonadotropic hypogonadism and hypothyroidism. These are the manifestations of hemochromatosis. So based on these manifestations, particularly this triad of bronze skin pigmentation and diabetes and some degree of liver involvement, we have to go for diagnostic evaluation. Initially, we will screen with two investigations. We will first do transferrin saturation. If it is more than 45, we will look at the ferritin. If it is more than 300 micrograms per liter, both these iron indices elevated, now you have a strong case for hereditary hemochromatosis. You can go ahead with the confirmatory testing. Right now, the confirmatory testing is genetic studies for the mutations. We will first test for the common mutation, that is HFE mutations. If not found, we will check for other atypical mutations. Anybody asks you, what is the gold standard? Do I need to do this gold standard test for all patients? Of course not. But if anybody asks you what is the gold standard, it is the liver biopsy, where again we are looking at the quantity of iron in the liver. For that, we are using this term hepatic iron concentration of more than 4 milligrams per gram of dry weight of liver. Means once we have done the liver biopsy, we have the sample. We are first making the liver dry, means we're getting rid of all the moisture part of it, and then we are looking at how much of iron is there in the dry weight of liver. If it is more than 4 milligrams per gram of liver weight, it is high. So quantification of the iron is important for the diagnosis if it is based on the biopsy. Okay, so the same thing that I discussed, I given you in the flowchart form, so that in the MCQs you can take the steps and reach the diagnosis. Once I've diagnosed, now I know that my patient's organs are burdened with high amount of iron, so I need to bring that iron down. So for that, the treatment of choice is going to be phlebotomy. We will make the patient bleed repetitively. Every week, 500 ml of blood is removed from the patient's body till I achieve my target transferrin saturation and ferritin values. Once it is achieved, we will put the patient on maintenance phlebotomy. In any circumstance, if the patient is not able to tolerate phlebotomy, if there are some contraindications for it, in such cases, we can consider iron chelating agents like deferoxarox or desferrioxide, right? So this is how we are going to manage the hereditary hemochromatosis. Okay, now I'm leaving you with a question. I will come out with a reel to address this question. What is hepatic iron index? Let me know through the Instagram. What do you think about hepatic iron index and what is its role in the diagnosis of hereditary hemochromatosis, and how is it going to help you to differentiate between the secondary iron overload and hereditary hemochromatosis? First one. And the second one, what are the indications for the liver biopsy? I will share the both the things through reels soon. Please watch out for the PW MedEd Instagram channel for more details. See you guys. See you soon in the next class. Till then, have a good time and good night. Medico, the RBC count production need not increase just because you have high amount of iron, because RBC production is primarily under the control. See, iron is just one of the raw material for the RBC production. RBC production is under the control of erythropoietin. So until and unless your erythropoietin is high, you will not have high RBC production, high hemoglobin production. So you won't end up with polycythemia. Only your organs get burdened with this excess iron. Just because I've made more iron available, RBC production will not increase. But instead, you can see this high amount of hemoglobin and high RBC numbers in smokers, because chronic smoking exposure triggers some degree of hypoxia, and that hypoxia increases erythropoietin, and you can end up with high hemoglobin. Or people living in high mountains, because of hypoxia, they will have high erythropoietin, so they, as a result, they can have high hemoglobin or high RBC count. And then the mutations in genes regulating erythropoietin production, and if there is uncontrolled erythropoietin production, someone can present with high hemoglobin. In that case, we will call it as polycythemia vera. In all those conditions, we can get not in hemochromatosis. Okay, so guys, that's it from me today. The notes will be available on the PW Method Telegram. Don't forget, I have given you 2 tasks. Try to find out the answer and watch out for the upcoming reels for the answers on these questions. See you guys. Bye bye. Good night.